So this talk could have been retitled BCG Potpourri, because it was really, we're going to be covering a variety of different topics, all about BCG, including some interesting data that's suggestive that there may be a role for BCG to prevent COVID-19 or not. And then also, importantly, the use of BCG for healthcare worker protection for folks who are going to be working in high prevalence MDR-TB areas. So to begin with, so I have no conflicts of interest. Our learning objectives are really sort of threefold. Number one was just to review what we know about the use of BCG to both prevent TB disease and infection, as well as some interesting non-TB specific benefits. And then number two, we'll change gears a little bit and talk about the role of BCG in the recommendation. Oh, it looks like I just got muted by the host.
You're back on. Sorry, Sylvia.
Okay.
Sorry about that.
It's okay. Okay, we're going to talk about BCG and for folks who are going to be working in high MDR-TB areas. And then lastly, I just wanted to make sure that folks had access to good resources on COVID-19. So we have a number of links. Great, there's a couple of acronyms we'll be using. So let's sort of it was really fun to remind myself about the history of BCG. So it was originally developed by Galmet and Guérin and from M. bovis, and it was recultured over 230 times over 13 years to create this non-pathogenic strain of what we consider BCG today. It was first administered to humans in 1921. It was an infant who was hospitalized in France. And really, its use has been increasing since then, really scaling up prior to the 1970s. However, the WHO really made a strong recommendation for widespread scale up in 1973. It is the most, this is amazing, it is the most widely administered vaccine globally. There have been over 3 billion people who've received it. And in many parts of the world, greater than 90% of children receive BCG. So some of this will be review for many of us. So there's strong data to suggest that BCG prevents TB disease. The data is strongest that it's most beneficial in infants who've never seen any mycobacteria before. And what it tends to prevent is TB meningitis and disseminated disease. And for those indications, the efficacy is about 75 to 86%. There's also recent data that suggests that there's a longer term duration of protection, even in adults, for pulmonary TB in some recently completed studies of First Nations people in the US and the role of who received BCG during infancy and those who didn't, and they looked long term, over 60 years, about protection for TB disease. So we've talked about BCG appears to protect against the most severe forms of TB disease in children, and also potentially long-term outcomes of pulmonary TB in adults. There also appears, there's a suggestion that BCG might actually prevent primary infection as well. So in a recent systematic review and meta-analysis of a number of studies, nearly 4,000 individuals who had received BCG, it appeared that BCG also prevented primary infection. And then really exciting recently was this H4 IC31 vaccine trial where BCG re-administration was really almost like the placebo, right? And they found that individuals who had an additional booster vaccination with BCG had sustained prevention of IGRA conversion by about 45%. So it appears that BCG at birth might reduce the risk of infection, and a BCG revaccination strategy potentially reduces the risk of IGRA, sort of reduced IGRA conversion. So we've talked about BCG and its TB specific responses, But interestingly enough, BCG also seems to induce non-specific immune memory. And there's this concept of trained immunity. And so trained immunity is a non-specific memory-like immune response that's induced by some pathogens and vaccines, for example, BCG, which can confer antigen-independent protection against a wide variety of pathogens. And interestingly, BCG has been associated with a reduction in overall pediatric mortality and in additional infections that are unrelated to TB. And it's thought to be due to this induction of trained immunity. And what trained immunity means in 2 seconds is trained immunity refers to an increase in immune responses to unrelated infections mediated by the innate immune system, and specifically by monocytes, macrophages, and NK cells. And this type of immunity is really nonspecific, and it can either be due to the same or different microorganisms. And it's independent of T and B cells. So it's sort of like you're getting a twofer from BCG, both protection from TB infection, and all of these other nonspecific immune memory responses. So we think that's why there's this interest, there's all of this really interesting data that BCG has been associated with improved childhood survival overall, irrespective of TB mortality, as well as a reduction in overall childhood hospitalizations due to other respiratory infections and sepsis. There's other interesting non-TB associated uses for BCG, and I think we're all familiar of the use of BCG as an intravesicular, so right into the bladder installation to help treat non-invasive types of bladder cancers. And how that works is it seems to, and it's still a big unknown, although it's been used for many years now, but it seems to trigger multiple local immune responses within the mucosal surface, and which and has improved both treatment of cancer as well as long-term decreases in mortality for folks living with bladder cancer. BCG has been evaluated in experimental uses for a number of other infections, and there's data suggesting that it decreased the viremia of yellow fever from an attenuated vaccine strain. And also, the study came out about 2 years ago, or a year ago, that BCG appeared to be associated with a long-term reduction in hypoglycemia in folks living with type 1 diabetes. This was a very, very small trial, but certainly intriguing. So again, BCG appears to prevent the most severe forms of TB disease, especially in children, as well as it seems to be associated with these other sort of non-TB related infections. So what about BCG and SARS-CoV-2? So we're not going to go through all the papers today. I brought up, I'm showing one here that just has nice, easy graphics for us to be able to see over Zoom. So there's been multiple papers now that have looked at comparing the incidence of COVID-19 cases in areas where BCG is used versus where it's not used, or even in the same locality, but amongst people who've had BCG versus those who have not. And the overall take home for many of these papers is that they've observed fewer COVID-19 cases in areas where neonates are routinely BCG immunized. So this is just an example figure. You can see that yellow area, those are countries where BCG immunization is not given at birth. And you can see these are confirmed cases per 1 million inhabitants. And then in that pink area in the graph, you can see places where BCG is given at birth. You can see that those curves have a much more acute angle or much more higher. So it looks like there's more cases in places where BCG is not given versus places where it is given. And they looked at both cases per, so overall cases, they looked at overall deaths, as well as mortality rate. Now this is intriguing, but importantly, it's really important for us to remember that these are all ecologic studies, and they're really prone to bias from multiple confounders, including differences in the demographics from the disease burden, testing rates for COVID-19, where the stage of the pandemic is in each of these countries. So I think that this is interesting data to look at, but it's important that when we read these papers that we remember that these could be true, and unrelated. There's also a number of papers that have looked at, there was one, David Horn had sent it to me. It was quite interesting looking at in Sweden, and they didn't see the same pattern. So I think the data is really mixed, and this is all ecologic epi data. And so with all the important caveats for that. The WHO has made a very clear statement that they do not recommend BCG immunization for the prevention of COVID-19. And in fact, there was a large concern that if folks were diverting the already scarce supply of BCG for COVID, it could lead to increased poor outcomes associated with TB disease and deaths. And there were similar concerns, a number of op-ed pieces from the bladder cancer community. So currently, there is no recommendation for BCG to be used for COVID-19 prevention. However, we've talked about how that initial data was primarily ecologic, but currently there's now 19 studies that are registered at clinicaltrials.gov, and this was as of August 24th. The primary focus of most of these studies in terms of population is healthcare workers, thinking that those are the individuals who are at highest risk. However, there were a few studies that are also focused on the elderly. There's a number of different endpoints, including both confirmed COVID-19 infection, absenteeism, how many days of work people are missing, hospital admission, days of symptoms, and our most important outcome of all, mortality. Locations, these are really happening globally all over the world. You can see here Egypt, Netherlands, Mexico, etc. So these are the kinds of studies that we actually need to really get to really answer the question, is there any role for BCG in the prevention of SARS-CoV-2? So I said that this talk was going to be the BCG pro-puri talk. So now we're going to shift gears and now talk about the role of BCG for healthcare worker protection for folks who are working in MDR TB high prevalence areas. So again, just as a reminder, in general, the CDC does not recommend routine BCG vaccination in the US. However, one exception that it may be considered for healthcare workers as well as humanitarian workers who travel to work, so going from a low incidence setting to a higher incidence setting, in areas where the potential for transmission may occur, especially if there's inadequate transmission control practices, and also if the subsequent risk for patient exposure when they return to their normal work setting, if that risk of them having active TB that was unrecognized they would then put them at risk of infecting patients here in a lower prevalence setting. So there's some important caveats to this. So there's been no study that I'm aware of that has specifically evaluated BCG to prevent MDR-TB. However, in expert opinion, the thought is there's no real reason to expect that the vaccine efficacy would be affected by specific drug sensitivities or resistances. The other important thing is that there's really currently an absence of proven MDR LTBI treatments or after exposure. So not MDR TB active disease, but after exposure for LTBI. However, there's currently an ongoing trial, the Phoenix trial, and those results that are looking at different LTBI treatments in the setting of an MDR exposure. However, those results are expected in 2024. So within that context, BCG, I'll look at that comment later. So in that context, BCG can really be considered part of a comprehensive risk reduction strategy. And we have to remember what the contraindications would be. So we'd want to make sure that the person doesn't have a history of allergy to either the vaccine components or a history of serious reaction if they've received BCG in the past. In the US, we consider HIV a contraindication. if a person has congenital immunosuppression or if they're on immunosuppressive therapies, for example, high doses of corticosteroids, TNF alpha blockers, etc. And it's a live vaccine, and so it's contraindicated in pregnancy. In terms of timing, and this is the important part, I do some pre-travel visits, and folks often come like, a few days before their travel. And so it's really important that the optimal immune response probably occurs 2 months after the administration. And so ideally, if you were going to administer BCG, you'd want to give it about 2 months prior to departure. Now, there's likely still benefit with a just-in-time immunization if somebody's going to have an extended stay. And importantly, we need to make sure that we counsel folks to cover that draining lesion that can sometimes take up to 2 to 3 months to heal, as there can be infectious materials there. In terms of potential adverse events, the open sore, it's really almost nearly universal. Lymphadenitis can happen. People can have systemic post-vaccination symptoms, and then also disseminated BCG disease, which happens primarily in people who are immunocompromised. Like I previously mentioned, this really needs to be part of a comprehensive risk reduction strategy that has pieces that need to happen before travel as well as after travel. So before travel, it's important to take a good baseline risk assessment, including doing baseline LTBI testing, either with TST or IGRA. IGRA preferred if the individual has a history of BCG, HIV testing, and education on TB symptoms and infection control measures. And importantly, that person should be fit tested. After travel assessment really needs to include TB screening as well as LTBI testing 8 to 10 weeks after. There's a nice, you can see in the reference where this figure comes from. We won't go through the figure but in detail, but it's a nice figure that shows what's supposed to happen pre-travel and post-travel. Talks about the medical evaluation, including, importantly, did they have a history of BCG? Is there any concern for TB disease? Getting a good assessment, and if not, getting a good assessment of baseline TB exposure and LTBI status and what to do then. Fit testing, as well as risk assessment. So this is, I've gathered a couple of SARS-CoV-2 resources that I think might be helpful for people. The top one is actually based out of UW here, and if you click on that link or look at that, it includes treatment guidelines, and it really focuses on the different treatments for SARS-CoV-2. It has because of its funding mechanism, it's really focused on the US setting, and also has a list of numerous clinical trials and talks about how each of the potential treatments that are being evaluated, how they work. Additionally, there's the UW Medicine COVID-19 resource site. These are really sort of the different protocols that are being used within the UW Medicine system, but they really span everything from infection prevention and control to testing to cohorting, etc. The NIH has put out a number of different iterations of their COVID-19 treatment recommendations. The AAP has good recommendations to look at. This was especially important when we were trying to figure out the best way for women to safely deliver who may have COVID, including questions about breastfeeding and questions about where should the infant stay right when it's born. This is the link to the CDC webpage, the IDSA guidelines, and then also the DHHS guidelines for people living with HIV and COVID. There's the clinicaltrials.gov link. And lastly, Lit COVID is a subset of PubMed. And so if you click on this, this site is routinely updated with the new references regarding COVID-19. And this has a ton of preprints. So this is a way that you can sort of keep up to date with the literature on COVID. It's coming at us fast and furious. So a few key take-home points. BCG is the most commonly used vaccine worldwide, and there is some evidence to suggest that it has numerous non-TB specific benefits. We talked about pediatric mortality, hospitalization, etc., as well as its role for treatment of non-invasive bladder cancer. The data regarding, besides the non-TB specific benefits, currently the data regarding BCG and COVID-19 is primarily ecological. So importantly, there's no current recommendation to use BCG to prevent COVID-19. However, you saw there's multiple trials underway. I think there were 19 last time I checked. It's likely there's more. And then BCG should be part of can be considered part of a comprehensive package for risk reduction measures for healthcare workers and humanitarian workers who will be working in areas of high MDR TB incidence, where there's a high risk of transmission and the risk for infection is high. But part of that, that comprehensive package includes evaluation for contraindications. And the data is limited on, because our data is limited on MDR TB prevention, and the importance of us doing a good job at both pre and post-travel follow-up. So that was quite the whirlwind. There's 2 pages of references.